Thank you, and I'd like to thank the ICS Scientific Committee for giving me the opportunity to speak at this roundtable discussion today. I have nothing to disclose, and I'd like to talk about lifestyle interventions for the prevention and treatment of POP and what evidence we have surrounding any of those modifications. So there have been several review articles that have come out in the past decade about the etiology of pelvic organ prolapse. Most of these have been derived from large epidemiological studies or clinical studies where they've looked at associations between variables and have most concluded that the etiology is likely to be multifactorial and equivocal. So not much help. But what most have come up with is some fairly well-established risk factors, and these are parity, BMI, aging, and genetics. So pelvic organ prolapse manifests by one, loss of support for the organs of the pelvis. So in women, this means that the uterus, bladder, or rectum prolapses into the vagina, or indeed sometimes out of the vagina. How prolapse is measured depends on what definitions you use, and there's an anatomical definition, most commonly the POP-Q, which is a measurement of the leading edge of the prolapse in relationship to the hymenal remnants. There is now some suggestion in a document that's actually up for verification at this meeting to use variables obtained from imaging to help with the diagnosis of prolapse. And I urge you all to have a look at that document to comment on it. And it includes measurements from ultrasound, MRI, and CT. And then, of course, there's the questionnaire and the self-reported symptoms of prolapse, the most consistent of which is the feeling of a lump or bulge in the vagina. So it seems that prolapse is fairly common. But again, there are inconsistencies in the literature as to how this is defined. And so prevalence is highly dependent on which of these definitions you use. And it can vary widely from 5 to 32%. And it seems to be higher if you use an anatomical definition than if you just use signs and symptoms of prolapse. So most women, by the time they reach the middle ages of 50 to 79, will have some form of prolapse if you measure it on anatomical definition. What we don't know is how prolapse develops mechanistically. There is a lack of understanding of the biomechanical mechanisms of prolapse. And I'm not going to talk too much about that today, but I just want to throw that in right there. So in 2008, Delancey developed a lifespan model for pelvic floor muscle dysfunction, which is a very useful way of looking at it. And it takes into account the fact that the pelvic floor may develop a reserve, so that inciting factors which can compromise pelvic floor functions, such as childbirth, aging, even perhaps high-impact sport, may not result in symptoms of prolapse if the underlying symptom threshold is not crossed. So for some women, they can go through an obstetric event or, as I say, even some factors which are commonly incitable for pelvic organ prolapse and not get any symptoms. Whereas on the other hand, you might have somebody who's got relatively minor symptoms, minor inciting factors, and go on to develop symptoms of prolapse, such as, sorry, that was supposed to come in before lifestyle. However, what we do know, we don't know the answers as to why this happens, but what we do know is that there has to be some sort of balance. There has to be a balanced relationship between those structures that support the organs of the pelvis, namely the pelvic floor muscles, in the connective tissue, and intact innervation, and the pressure that is put on these organs from the abdominal contents, and because we stand on 2 feet, the gravitational loading of those abdominal contents on these organs of the pelvis. So you can imagine if the support structures are not functioning properly, or if the abdominal pressures or the pressures are too high, then prolapse will result. So we need to understand this relationship before we can start to develop better prevention and treatment strategies. Nonetheless, while we don't understand yet the mechanisms of prolapse, there is some evidence in the clinical literature to suggest that there are lifestyle risk factors which show associations between the development or the risk of prolapse, and these can be potentially modifiable. So these are the common sort of lifestyle factors that are quoted. So bowel dysfunction, in particular straining at stool, obesity, chronic cough, heavy lifting or occupations that demand heavy lifting, maybe high-impact exercise, and perhaps nutrition. And I'm not going to mention nutrition too much, but just to mention it because it is a relatively new area, but there's very little research on it, and it's a very difficult topic to research. What has come out so far in terms of research is mainly from the developing countries, where they've looked at factors such as undernutrition, anemia perhaps, and suggested that because of this there's some lack of tissue tensile strength due to dietary factors, but very little is known about it. If you look at the other factors that I've listed here, you can imagine that these have been listed because the assumption is that all of these factors increase abdominal pressure while you're performing them. This is sometimes an untested belief, but that's why they're there. So what about the evidence? This is by no means a comprehensive list, but what I've tried to do is just select some of the studies that have looked at the relationship between bowel dysfunction, or in particular straining or constipation, and the risk of prolapse. And it varies according to how you define prolapse, and it also varies to how you have collected data on bowel dysfunction. So perhaps if you have a look at the Varma study in 2008, they found an odds ratio of almost twice the risk of prolapse signs and symptoms associated with bowel dysfunction. The Swift study looked at the relationship between bowel dysfunction on questionnaires and the POPQ, and 47% of their cohort, which was a large cohort, it was part of the POST study, and they found that there was no relationship between constipation and risk of prolapse. But if you look here, I didn't highlight this one, but the ARIA study used pretty much the same assessment methods, much smaller participants, much smaller cohort of participants. But in fact, there was a 4 times risk of a relationship between constipation and prolapse. So the evidence, I'm afraid, is equivocal. What is unequivocal is that there are definitely substantial increases in pressure during straining. And you can imagine if this is sustained over several years, then perhaps the support systems of the pelvic organs may indeed be compromised. So I'm just going to play you a little video. As Chantel mentioned, we presented this at the IUGA meeting last year, and it is just a real-time visual aid to show you what happens for abdominal pressure during some of these activities. So this is using a novel intravaginal pressure sensor which we have developed at the Auckland Bioengineering Institute. It is wireless, and it's self-inserted, relatively easy to use, and I think quite interesting. So hopefully this will play. So this is just straining now. I've blocked out her face, but you can imagine that she really is straining. So if you look at the axis, the y-axis, you'll see that the pressure rises to about 110 millimeters of mercury during the strain, and a slight decrease on inspiration, which is... So do this for 10 or 20 years and maybe, but we don't have enough evidence yet. What about obesity and prolapse? So there have been several systematic reviews that have come out over time of the relationship between urinary incontinence and obesity, and these have shown to be very strong. There's also strong associations between obesity and intra-abdominal pressure. These studies have measured pressure usually using urodynamic catheters, be they and for some of the studies, they've actually fluid-filled catheters, so there's some caveats around that. But there is a relationship between abdominal girth and increased IAP, to the point where if you have a 1 unit increase in BMI, it could correspond to a 0.3 increase in centimeters of water. So there is definitely a relationship there, but the association between obesity and prolapse is not as clear. So again, looking at the studies, based on questionnaires, a BMI between 25 and 30 will give you almost twice the risk of developing prolapse. Some variability between the studies again. Whitcomb, this is the secondary analysis of the POST study, so I presented that earlier in relationship to bowel dysfunction. So many of these studies are huge generalized, general population-based studies, and they've looked at all the variables that could contribute. Dividing obesity into obese over 30, morbidly obese 30 to 40, and severely obese over 40, all the symptoms of both prolapse and urinary incontinence increased incrementally with increasing obesity. Not particularly surprising. The Samuelson study looked at weight per se, and I must say their mean weight was fairly low, so they didn't seem to find an association with POP. But perhaps the most compelling evidence for obesity and the relationship between POP is a study done in 2013 by Koichi, and I apologize if I pronounced it incorrectly, where they looked at the effect of bariatric surgery in women who presented. 100 women presented for this weight loss surgery, and all of them, well, 80% of them had symptoms of prolapse prior to surgery, measured both anatomically and symptomatically on questionnaire. And post-surgery, there was a reduction by 74% in all the symptoms, and an average weight loss of 10 kilos for each of these women. So fairly compelling evidence then that reduction in that mass that's acting on the organs of the pelvis definitely makes a difference. Again, this is just some little data from the study that we're conducting at the moment using our intravaginal pressure sensor and looking at the effect of BMI. We don't have large numbers, but the women who have been in our study, just this is simply lying, sitting and standing. For those with a BMI of over 30, sitting seems to be the most inciting factor for increasing abdominal pressure. Interestingly, not yet lying and not yet standing, because there's quite a bit of overlap, so there won't be any differences in this population at the moment, but we only have 7, so just to show you. What about heavy physical work or occupational work? So the Danish nurses study is often quoted, and they say that there's a prevalence of about 1.6 odds ratio of women who ended up with surgery for prolapse, but this didn't account for parity. This was back in 1994. In 2007, Larson looked at a series of women who had enrolled in a military-style training camp for the summer, and 37 of these did paratrooper training, and they found that they were twice at risk, or nearly 3 times at risk, of worsening symptoms of POP and an increase of stage of prolapse following paratrooper training. So don't do paratrooper training. Well, if you don't want POP. The other frequently quoted study is the Italian study by Schifferanio in 1999, where housewives self-reported heavy lifting during their daily tasks, and they were 3 times more likely to undergo surgery for POP compared to their compatriot office workers. Again, looking at the evidence, it is quite variable, depending on the questionnaires and how they measured heavy lifting. So when it was weight-related, they seemed to have an odds ratio of about 2, the risk of about 2. So there was no clear dose response. Interestingly, the study by Bracken in 2009 showed an almost 9.6 odds ratio in women who reported heavy occupational lifting associated with stage 2 prolapse. But besides that, the relationships are relatively low with the risk of prolapse. So what about exercise? Well, we know that exercise is good for you. There's the Australian, New Zealand national guidelines, and I'm sure everywhere else, recommend at least 150 minutes of aerobic exercise per week, or 75 minutes of intense aerobic exercise per week. I think you did 30 now, maybe? Mm-hmm. Okay. So the premise is we need to get ladies or everyone active. Being sedentary is the new smoking. You can't be sedentary. But what is interesting is that there's a study in 2013 that came out in the ASCM journal that looked at the top 20 trends for the exercise industry in 2014. And while some of those that were there for many years have now dropped off, such as Pilates or core training or some of those, top of the list for 2014 is this high-intensity interval training. This is the largest trend in the exercise industry for last year. And I think that includes training such as CrossFit, which some of you may be familiar with. It's a very intense training. And several studies have looked at intense training with the prevalence of urinary incontinence and found that there are indeed high associations between urinary leakage and some high-impact exercises. Again, it depends on how urinary incontinence was measured. How am I doing?
You're a little bit over time, but
okay.
Go on.
Whether it's measured with a pad test or whether it's measured on questionnaires, and quite a wide range depending on exercise. 80% of trampolinists, where about 25% of women in general exercise experience leakage. But what about POP?
Okay, that's fine. We'll just have a little bit less question, but go on.
Okay, so sorry. So Nygaard and colleagues have just released a systematic review looking at physical activity and pelvic floor disorders, including prolapse. And what she came up with was none of the studies support an association between exercise and POP. There were only 2 that I could come across that looked specifically at prolapse using the POP-Q, one by Ali Ross in 2009, where he got women who were scheduled for prolapse surgery, and he examined, or the researchers examined them for stage of prolapse just prior to surgery, asked them to do an hour of intense exercise, which included walking upstairs, running on the spot. I think there were some star jumps in there. They then got them to rest and re-examined them the next morning, and they found that for most, the stage of prolapse had increased, but not for everyone. For some, the stage had reduced, and for some, it had remained the same. So again, we really need to explore those mechanisms of prolapse. What is it that for some women will make it worse, and for others, it doesn't make a difference? The other one that was interesting was a study by Nygaard herself, where she questioned women in their 50s and beyond who could remember that they were very active during their teen years in intensive exercise, and I think that was for 21 hours per week, and they found that there was an increased incidence in prolapse, POP stage, measured anatomically, not symptomatically, in their middle age. Coughing is often cited too as an inciting factor for prolapse. It is indeed an inciting factor for urinary incontinence, but the evidence is variable. Olson suggested smoking doubles the risk. The Women's Health Initiative suggested smoking was protective. I'm not suggesting that you use smoking as a treatment option for women with prolapse. But the POST study found minimal association, and the only one that really looked at asthma as a chronic cough found an odds ratio of about 1.2. Again, smoking protective, maybe I should leave that out. However, what is unequivocal is that there are substantial increases again in abdominal pressure during coughing, surpassed only perhaps by trampolining. So again, this is just one of these little videos. Where you can see the pressures increase. This is in kilopascals to about 17 or 18 kilopascals. Sometimes 150 odd. So, for prevention, because very little is known about the efficacy of any lifestyle modification in the prevention of POP, there are no studies to test an intervention, be it for bowel dysfunction or for exercise or for heavy lifting. Perhaps the most compelling evidence is from the bariatric surgery, where we saw a reduction in weight, and that certainly was associated with a reduction in prolapse. I'm just going to mention this, but I won't spend too long on it, is that very recently, in 2014, Don Wilson and colleagues suggested a risk prediction tool or risk prediction model that was formulated from the PROLONG study, which you may or may not be familiar with. This is a study that's following a multi-centered study following women from the time of birth, and they're now at the 20-year mark on the course of prolapse development. And they've looked at certain variables using statistical regression and come up with, I think there are about 6 different variables which may be predictive for POP. The only one that is modifiable, if you're looking at lifestyle, is weight. All the others, unfortunately, we can't change. So aging and family history of prolapse, weight of baby, that kind of stuff is also in this potential model, and the mnemonic stands for those things, but I can't remember what they all stand for.
Jenny, I'm going to ask you to maybe 1 minute.
Okay,
Sorry.
so this is, I suggest, a way forward.
Good.
Consistency in terminology for the definition of prolapse, so we can look across the literature to compare POP. Well-structured prospective clinical trials, and in addition, because I work in a bioengineering institute, I would like to suggest a multidisciplinary approach towards the mechanisms of prolapse. Can we look at why, the causes, not just the associations? And in order to do that, I would like us to think outside the square, maybe even a paradigm shift in the way we think about prolapse. If we can begin to sort of understand the mechanical environment and how the tissues respond to loading, and what that response is, only then can we really start to develop better prevention and treatment strategies, probably on a patient-specific basis and not just on a population basis. So these are my acknowledgements, and I apologize for going over time.
Thank you very much.